Okay, we're going to go ahead and start. Wait till we get Don back. Good afternoon. My name is Wendy Everett. I'm the Vice Chair of the Health Policy Commission and delighted to welcome you back. We are missing a couple of commissioners, a few of the people very closely associated with the state are on a conference call, and they'll join us very shortly, but we decided we really didn't want to wait any longer. So it's really my pleasure this afternoon to introduce Pamela Lomax. Pamela is the Deputy Auditor for Administration and Finance for the Commonwealth, and has held positions at Suffolk University, at Harvard University, and at MIT prior to her most recent very extensive experience in state government. Many of you may not know that the Auditor's Office is charged with the responsibility of evaluating all of Chapter 224, the 2012 Healthcare Cost Containment Law in Massachusetts. This is no small job, as you can imagine. Pamela has overseen this evaluation over the past several years, and I had the privilege of serving on the advisory committee for the auditor. So this is an extraordinarily tall order, and the auditor's office finished the evaluation and published this report in just the past several months. Pamela was an extraordinarily warm, thoughtful, and creative colleague to work with in this process. I'm thrilled to have her with us today and just invite you to join me in welcoming her to give her presentation. Thank you, Pamela.
Thank you, Dr. Everett. You're very generous. Good afternoon, everyone. I bring you greetings from Auditor Bump, who is unable to be with us today. As Dr. Everett said, as one of the deputies in the Office of the State Auditor, one of my responsibilities has been to provide oversight of our Chapter 224 work. But the bulk of that work was led by Dr. Umberto Reynoso, who some of you know, and you have worked with him as well. The Health Policy Commission, CHIA, GPH, all assisted in various aspects of our work, including reviewing drafts, offering feedback, and providing data. The Commonwealth Corporation, one of our quasi-agencies, contributed the research on the healthcare workforce. Our Chapter 224 Advisory Committee, and many of you here on the board, generously shared your valuable time and expertise, and we do thank you for that. Your contributions were invaluable and greatly contributed to our analysis of the data, leading to the report findings that we do hope will help guide the conversations as we continue to develop strategies to address healthcare costs. Many of you know, as Dr. Everett referred to, the 2012 Healthcare Cost Containment legislation directed our office to provide a comprehensive review of the impact of the law on healthcare payment and delivery systems, the impact on healthcare consumers, the healthcare workforce, and the general public. And as Dr. Everett noted, it was a very tall order. With a great team on this project and enthusiastic collaborators, we issued our report at the end of June, and it is available on our website, www.mass.gov/auditor. I also have hard copies of our executive summary with me today for those who are interested. In keeping with the theme of today, looking back, looking forward, I'd like to share a brief overview of our report and talk a bit about our plans for our Chapter 224 work this year. It goes without saying that at the federal level, the continuing discourse around healthcare will be in flux in the near term, with unknown impact to the states. Within this atmosphere of uncertainty, Auditor Bump has continually said that we do things differently here in the Commonwealth. By enacting Chapter 224, our legislature had the foresight to also want to know how the law was working and the initial impact it was having in various groups. We applaud the legislature for recognizing the need to understand that legislative impact. More importantly, our analysis indicates that policymakers really prioritize the right areas on which to focus. We often talk in the auditor's office about the importance of measuring and understanding outcomes as a strategy for continuous improvement. And our Chapter 224 report gives us a snapshot of just that. I'd like to highlight specific areas of promise and concern in a brief overview of our findings. In reading our report, you will find that each chapter corresponds to a research question that is based on the legislative language of Chapter 224. What does this work mean as we all work towards a more affordable and accountable healthcare system in the Commonwealth? While our report does not offer explicit policy recommendations, we do want readers to consider the policy implications of our findings. In Chapter 1, which focused on healthcare cost, we relied on the great work of HPC, CHIA, and others to inform our work. While I won't repeat what you are hearing in much greater detail today, I would like to emphasize 2 points from that chapter. Although the Commonwealth's insured rate is still the highest in the nation, Latinos, people with low incomes, new residents, and young adults are at a much higher risk of uninsurance. And 2, because the Commonwealth is a major purchaser of health services through Mass Health and the GIC, this market clout should continue to be used to explore innovations in plan design and care delivery reform. Chapter 2 of the report focuses on access and quality of healthcare services for children, older adults, low-income individuals, and people with disabilities. The data confirms that after the enactment of Chapter 224, the Commonwealth maintained access to care for these populations. But as you've heard throughout the morning, we continue to struggle with high levels of hospital readmissions and avoidable ED visits for the population at large. The implications of the findings in this chapter are straightforward. Low-income people continue to suffer from persistent disparities and need continued advocacy and policymaker support in expanding oral health coverage, improving some cancer screening rates, and increasing well-child visits. It does bear repeating that the need for increased efforts in developing strategies and interventions to reduce unplanned hospital readmissions and avoidable emergency department visits is a must. Chapter 3 of our report focuses on access and quality of healthcare services related to primary care and behavioral health. The data informs us that the 2 major goals of primary care under Chapter 224, improving coordination of care and shifting more visits to non-physician primary care, have not yet been achieved. And despite some expansion in psychiatric beds and treatment, there remains an inadequate supply of behavioral health treatment resources. New or enhanced policy in this area should include targeted efforts to improve care coordination, perhaps direct investment by the state in new mental health facilities, perhaps increasing Mass Health reimbursement rates for behavioral health services and care, and advancing the integration of primary care and behavioral health. The healthcare workforce is the focus of Chapter 4 of our report, and that work, as I spoke earlier, was completed by the Commonwealth Corporation and the Center for Labor Markets and Policy at Drexel University. A major finding out of this work is that while the Commonwealth's healthcare job market has experienced job growth in both high-skilled jobs requiring a bachelor's degree or higher and in low-skilled jobs requiring little or no certification, we do not have enough workers to meet the demand, specifically for home health care aides and personal care attendants. As the healthcare industry transforms care delivery systems and shifts focus from inpatient to outpatient settings, there is a looming crisis regarding our healthcare workforce and the ability to meet the demand for care. This crisis includes an urgent need to increase the number of direct care workers and ensure they are paid a living wage. Policymakers will also need to pay particular attention to the benefits cliff effects in occupations where there are substantial workers who participate in non-cash benefit programs. Policymakers and others must also understand the demographics of healthcare workers in the Commonwealth. The healthcare industry in Massachusetts employs greater numbers of women, African Americans, and Latinos than all other non-health industries combined. I'll say that again. The healthcare industry in Massachusetts employs greater numbers of women, African Americans, and Latinos than all other industries combined. We must acknowledge that industry and policy changes regarding this workforce impacts these groups of workers the most. Our last chapter in the report focuses on public health. Has Chapter 224 had an impact on reducing preventable health conditions, improving employee wellness, and reducing racial ethnic disparities in health outcomes? Using the data provided by DPH, the APCD, and other sources, we have found that there have been some positive trends since the enactment of 224, but disparities in health outcomes continue to exist. Some of our findings include that Asians had improved health trends for more than half of the 27 measures we focused on, such as colorectal cancer mortality, prostate cancer mortality, infant mortality, and asthma, to name a few. Whites had improved trends on 7 measures, such as having personal health providers, low birth weight, and making a recent dental visit. For African Americans, more than half the measures showed deep disparities in several areas, including infant mortality, prostate cancer mortality, oral health, obesity, and overweight. Latinos had a worsening trend for skipping a PCP visit and making a recent dental visit. We note in the report that increased investment in public health systems is critical to capitalize on our current progress, to scale prevention and wellness initiatives, to increase positive outcome trends, and to reduce health outcome disparities. As we look ahead, our work this year will include expanding several areas of our June report, including adding data to the existing quality and public health measures to test the trends we observed from 2012 or before. We are exploring using data to determine ED visits by geographic area and include social demographics to compare to other areas in the state with less ED use and perhaps different socioeconomic status. We are also exploring conducting a factor analysis of variables related to prevention and health outcomes by race and ethnicity, and determine the feasibility of entering those results into defined geographic areas so that we can all better understand the geographic differences regarding health outcomes in the Commonwealth. And as we did previously, we will continue to align some of our ongoing audit work with our Chapter 224 work. Through this work, the Office of the State Auditor has the goal of adding value by sharing information that can be used by researchers, advocates, and policymakers as we continue to work towards a more accountable and affordable healthcare system that supports and provides opportunity for all who live in the Commonwealth to experience positive health outcomes. Thank you very much for allowing our office to share some of our work with you today.
And thank you very much. This was an exceptional piece of work, having watched what went into it, the difficulty reconciling all of the data, and your office's ability to really come up with some very specific summaries and policy recommendations, particularly around the issues of disparities. Let me just take a moment and open it up to the rest of the commission. Anyone who has comments or questions. Marty.
Thank you, Pamela. I'm impressed with the breadth and scope of your report. I did note, however, in Chapter 3, there was a reference to increase commitment by the Commonwealth to facilities, particularly around behavioral health. Could you say a little more? Is that the kinds of facilities, outpatient, inpatient? Are there geographic weaknesses that were identified in your report, or just a little more to sort of appreciate what that is in reference to?
Yes, absolutely. And I would like to turn to Dr. Reynoso to help fill us in on
I
that.
don't remember the answer. The report is so huge. Just to remember every single detail.
But we will look back on the raw data and circle back to you.
Thank you.
Great. Any other questions or comments? Yes.
Thank you. Thank you for the report, and particularly the focus on the healthcare workforce. We read that with great interest, particularly as you referenced the population that is typically healthcare workers, women, minority, people of color. What the other, I think, fact that came out in that study, correct me if I'm wrong, is that through the review that wages for the healthcare workforce remained stagnant during the course of the time period that you looked at, while everything else was increasing. And to your point of this being a crisis of care, where we know that the increased demand is going to be there and the workers are not, and how we're dealing with, as you said, everyone they should get paid a living wage. What were your thoughts or comments about the impact of low wages, and also referenced in the briefing that I went to or on the report, the immigration policies of our country right now and its impact on getting workers here to meet the demand, particularly in long-term care spaces?
And so before I do respond, I just want to preface my comments that we subcontracted this work to the Commonwealth Corporation and Drexel University, but two things in particular stand out from conversations with that team. One is that the wage issue, as well as working conditions, are really part of the issue in finding reliable people or people in general to fill some of these jobs. In some of the field research and conversations that the team did, one of the home health care providers noted that his competition for workers were retail jobs and Dunkin' Donuts. Retail jobs and Dunkin' Donuts facilities are able to provide steady schedules. They might be located near public transportation, and they might pay more. And so people would rather have the convenience as well as more money in their job situation. And in terms of immigration, again, comments from some of the field, we have nursing homes in the Commonwealth who are staffed almost completely by immigrants. And the issue of some of our Haitian residents losing that protective status in the upcoming months may put their services on the line in terms of being able to actually field full staff and serve the people who live in their organization within their communities.
Okay, thank you. Thank you again, and we'll really look forward to working with you on this next phase.
Thank you very much.
You want to take over?
So I'm going to ask our next panel to please join us at the witness table. We're going to shift topics a little bit here this afternoon and talk a little bit around some of the changes in our healthcare market and how those changes have impacted cost, quality, and access. And really along the same themes of today, looking back and looking forward. What can we learn from past experience that could help inform our policy action moving forward? So I'm going to take a few moments and present some information to both our Board of Commissioners and to the public and to our panelists around this particular issue. And we'll take a little bit longer in presenting this data than I typically do, because this is the first time that we've been able to present data that looks at some trend lines and observes some trend lines pre and post transaction in our healthcare marketplace. Chapter 224 recognized that changes in our healthcare market, provider market, can have significant impacts on healthcare costs and spending, and charged the HPC with monitoring these changes. Since 2013, the HPC has received 85 notices of material change and has moved forward with a cost and market impact review of 8 of them. However, this work was largely prospective. In addition, the HPC has been engaged in monitoring what the impacts on cost, quality, and access have been after these significant market changes have occurred. And today we want to preview some of that work. Specifically, one of the big challenges Massachusetts faces is that too much of our care is delivered in expensive settings. For example, care is being delivered in teaching hospitals and academic medical centers when it could safely and appropriately be provided at community hospitals. Quote, keeping care in the community is nearly always cited as a goal in new affiliations, but we know that keeping care in the community is challenging. In this year's pre-file testimony question, we asked providers what do they think some of the biggest barriers are to shifting care to more efficient settings. And you can see on this slide some of the most frequent responses that we had. Patient preferences and perceptions of quality, physician preferences, geographic proximity, and insufficient cost-sharing incentives. Today, we want to show you how inpatient site of care has changed after community hospitals have affiliated with larger provider organizations. Specifically, we looked at 14 hospitals that were acquired by or started contracting through a larger provider organization between 2011 and 2015. For all of these transactions, the parties indicated that keeping care in the community was one of their goals. To examine how these new affiliations may have changed where patients are seeking care, we looked at the patients who live near the community hospital that was part of the transaction and who sought low acuity, community appropriate inpatient care before and after each of these transactions. We looked at it at each hospital's share of these discharges for the area in order to control in the overall number of discharges. And we worked with clinical experts in order to identify a set of inpatient care that we feel can be safely and appropriately delivered at all community hospitals. These community appropriate discharges, or CADs, as they will appear on the slides, do not involve clinically intensive or specialized procedures, such as major chest or trauma procedures. Overall, it is a conservative list, and in 2015's these community-appropriate discharges accounted for about 41% of all discharges statewide. Finally, and I want to emphasize this last point here, for many of the transactions, we do not have a lot of post-transaction years to study, so we may not be seeing the full extent of the transactions yet. And of course, we weren't able to say why site of care has shifted or not shifted. It could be related to factors that are frankly outside of the control of the organization. As we've discussed at this point, over time, a greater share of low acuity community appropriate care has been going to teaching hospitals and to AMCs and less to community hospitals. Overall, it appears that few community hospitals that have affiliated with or joined larger provider organizations have reversed that trend. And for the next few slides, I'm going to walk through some specific information relevant to each of our panelists here today. First, starting with Lawrence General. Lawrence General experienced a decline in its share of community-appropriate discharges in its service area after its 2014 affiliation with BIDCO. We found that this decline was greater than the statewide trend for community hospitals. We found similar trends for other hospitals that had begun contracting with BIDCO, including Anajakes and Cambridge Health Alliance. Turning now to Cooley Dickinson. Cooley Dickinson experienced a steady decline in its share of CADs both before and after its 2013 affiliation with Partners. This decline was greater than the statewide trend. Teaching hospitals gained shares of CADs in the Cooley Dickinson community after the transaction at a slightly greater rate than the statewide average. And I would note this was not driven by more volume going to Partners AMCs downtown, however, but rather to Bay State Medical Center and its hospitals in that close geographic area. Turning to Steward, we see the community hospitals acquired in 2011 and 2012 also continued to lose shares of community-appropriate discharges in their service areas. Nashoba Valley, shown here, had a relatively small decrease in its share of community-appropriate discharges from the last year for its acquisition, 2010 to 2016. And this trend was very similar to the statewide trend. Shifting to Merrimack Valley, we saw that Merrimack Valley was losing shares of community-appropriate care both before and after Steward acquired it in 2011 at a rate faster than the statewide trend. However, when Merrimack Valley and Holy Family merged in 2014, we look at their joint shares together, and we see that by 2016, the hospital's joint share was starting to go back up again. Finally, for Steward, we examined Morton Hospital, and Morton experienced a significant decline in its share of community-appropriate discharges after its affiliation with Steward. Here, too, teaching hospitals and other AMCs continued to gain that share of the community-appropriate discharges from this area. Finally, in contrast to decreasing shares of community-appropriate discharges at community hospitals statewide, the Northeast hospitals, Beverly and Addison Gilbert, experienced an increase in their share of community-appropriate discharges after affiliating with Leahy. Even after a slight reduction in 2016, the Northeast hospitals had a higher share of community-appropriate discharges than before the transaction. Similarly, when we look at Winchester, Winchester's pre-transaction trend of decreasing share of community-appropriate discharges also stopped after it was acquired by Leahy, with a slight increase in its share from 2014 to 2016. This is the opposite of the statewide trend. As I noted up top, this is just a preview of some of the work that we have been done monitoring the impact of past transactions. And here we focused on one specific metric, but want to emphasize that there are many different metrics that one may want to analyze in analyzing the impact of transactions, as shown on this slide. We look forward to presenting more of this data and information to our board and to the public at future meetings. And we hope that this analysis at least opens up a panel discussion about the barriers to keeping care in the community, how those barriers can be overcome, and the impact of provider changes more broadly on healthcare costs, quality, and access. And with that, I will turn it over to Chairman Altman to key off our panel.
Thank you, David. Again, the way we've operated these panels is we're going to ask each of you to introduce yourself very briefly and which organization you're affiliated with, and not to go into any detailed presentation. Then we will have questions, comments back and forth, and hopefully information that you want to make available to us will come out. We didn't want to set you up in any particular way given this information, but some of it is a little troubling because when we get proposals put before us to affiliate, to merge, it usually is in the context of improving access and lowering costs and stuff like that. And as David pointed out, in many situations, thus far, we have not seen that. So there may be reasons for it, and if there are, we would more than welcome your comments. But it is, the reality is what we've seen. On the other hand, there have been a few situations where it has gone in the opposite direction, and I want to acknowledge the head of Leahy, who's here, where in fact it moved in the opposite direction. So with that as an introduction, I'm going to turn, Peter, maybe you can introduce yourself and what organization you're with.
Sure. Hi, I'm Peter Slavin, President of Mass General Hospital, one of the founding hospitals of Partners Healthcare.
Good afternoon. I'm Howard Grant, the President and Chief Executive Officer of Leahy Health and Leahy Hospital and Medical Center.
Good afternoon. I'm John Polanowitz. I'm the Executive Vice President of the Hospital Services Group at Steward Healthcare.
Good afternoon. I'm Diane Anderson. I'm the President and CEO of Lawrence General Hospital. We're a regional medical center in the north of Boston, Merrimack Valley area.
Thank you very much. So let me just start off, and then I'll turn it to my colleagues, and ask each of you or any of you to comment on the information that David presented. Peter?
Thank you, Mr. Chairman. I guess I have three reactions to the data. One, I think it is hopelessly confounded by other things going on during this period of time, namely the shift of care from the inpatient to the outpatient setting, a shift that probably is able to happen more at community hospitals than at teaching hospitals that have generally sicker and more tertiary and quaternary patients. So I think that is a factor that is confounding the results that you're seeing. Secondly, I think it underscores the fact that proximity is a major factor in how easy or hard it is to get this done. We've been working really hard with some of the community hospitals within Partners or others that we're affiliated with, and it is hard for the reasons that you mentioned to get this done. But at places like the Brigham and the Faulkner that are just a few miles from one another, thanks to some heroic efforts at both places, a huge amount of orthopedic and primary care has indeed been shifted from the Brigham to the Faulkner, and congratulate Howard and folks at Leahy and Winchester for doing that as well. And then, well, I guess those are the two points. And then as far as Cooley Dickinson goes, that's the third point that you referred specifically to. As David mentioned, that change is not the result of care moving to Boston to Mass General Hospital. It's a result of an aggressive effort by Bay State Medical Center to take patients away from Cooley Dickinson Hospital. Cooley Dickinson has seen its market share in that region decrease by 5% since our affiliation, and we're working with them to figure out how to counter those trends as we speak.
So those are very helpful comments. You know, it is not our intent to find problems, quite the opposite. I think we would be very happy to find things that really move in the right direction. And to the extent that we could dig in deeper, the way you said, and understand, that would be fine. So maybe your staff could work with ours to improve that.
Could just ask a follow-up question. Could you talk a little bit more about the shift from inpatient to outpatient and how it specifically affects the sort of stability of people staying in academic medical centers?
I guess my point was that it is typically short-stay admissions that are most amenable to moving to an outpatient setting. Community hospitals have a higher proportion of those than teaching hospitals do, and so are more ripe for that shift. And during this period of time, there have been an enormous number of conditions that have shifted to an outpatient setting. So I suspect that that's having a significant impact on this data, and I would expect that it would result in trends like the ones that you're seeing.
So do others want to comment on specifically on the data that, yes? Diane?
Thank you. So I'm very fascinated with seeing this data because I'd like to share a little bit of a different perspective and experience that we're seeing. And this is from our most recent data in 2017. where we're actually seeing an increase in volume. We've seen a 7% increase in our volume overall, significant increase in surgery and other particular specialties. And we're also seeing a decrease of the amount of patients we're sending to Boston and an increase in the amount of in-network utilization. All that, along with that goes a decreasing total medical expense of 11%. So we're seeing all things starting to go in the right direction. Again, I think it takes a long time to shift all of these factors. And I think that it would be helpful if we could think together of things we could do to make that shift happen more, faster. But we're definitely seeing the trends in the right direction. There's no question about that. Still a lot of potential. We know we certainly in the whole area have an ongoing problem without migration, the proximity to Boston, the reputation of the academic medical centers, the ease of physician referrals, all those things go into it. But through all of our efforts, which include, by the way, significant investment in our facility, state-of-the-art ORs, brand new ICUs, hiring our own traumatologists and intensivists, all of these types of investments are also part of why we've been able to keep care local, there's no question about that, as well as being at risk for our with our BIDCO doctors for their commercial and Medicare patients. But I have to say also that in order to continue that kind of investment, to keep the level of quality of care and the capability at a very, very high level for the community, that's going to take ongoing investment, and we have to be sustainable, which again calls up the whole issue about price variation and being adequately paid. But we have the solution if we can only be sustainable to continue the journey.
Other
To follow up on Diane's point, if you looked at the example that was given from Holy Family, you have the Haverhill Hospital, the former Hale Hospital, that had been in decline for some years under Essent. We took it over, and once we started investing in both the organized medical staff, the facilities themselves, and the staff there, and brought it under one license, we've actually been able to start to reverse that trend. I think to your point, that doesn't happen overnight, and frankly, it's a challenge every day with the ongoing issues around the price variation to do those kinds of investments in the community, particularly for us. Right now we have 388 psychiatric and substance abuse beds. I think we're the largest inpatient hospital provider of psych beds in the system. And in fact, our system over the last 3 years has continued to add psychiatric beds. And it's a real challenge for us to do that, which is the right thing to do for us and our accountable care model, to do that when we have the issues around price variation and transfer of patients into higher cost settings.
Doctor?
So I think the results that you presented reflect a commitment that Leahy Health made to enhancing care in the community setting when originally the old Northeast Health System in Beverly came together with Leahy 5 years ago, and subsequently Winchester. The board composition, which consisted of equal representation from our community hospitals and our tertiary facility, reflected a commitment that board made to do everything that we possibly could to take a look at what needed to be done. And we have actively managed that process literally every single day since the Leahy Health System has existed. Number one, we told our employed primary care providers who were closer to our community hospitals that they should actively send their patients to private practitioners in the community, to local emergency departments, and not necessarily send to Burlington, which historically had been the case. We wanted the patients to be cared for close to home in their community hospital. Number two, we actively manage patients in our emergency departments so that if a patient who presents in Burlington has a primary care provider in a community hospital setting, we offer that patient the opportunity to be cared for in Winchester or in Beverly. And in fact, we transported last year over 1,000 patients, always subject to patient choice, back to their community hospital for their hospitalization. We just had a Joint Commission surveyor who was a longtime ED doc from an academic medical center who said he'd never seen that before. We do it every single day, and it's appreciated by our patients. Number three, we've got one intensive care group that's managing the ICUs in each of our hospitals. We actively transfer patients back to ICUs in the community setting when it's appropriate for their care to be delivered in that fashion. Number four, we send Lahey specialists from Burlington to provide care to live and work in community hospital settings so that more services can be delivered at those institutions, and it's resulted in more care being kept locally. So it's a process that we look at on a monthly basis with the data. We're committed to keep the care local, and we're committed to keeping the costs of care down. And that's why I think we've gotten the results that we were able to demonstrate today.
Okay, Ron?
I'd like to take a different perspective, look at a different perspective. I believe every one of your organizations, you need to protect your base of business, and the other objective is to expand. That's what businesses do. That's what organizations do. And if that's going to be the case, and especially when you look at preferences and what the perceived benefit is of moving into one of the major institutions versus a community hospital, unless, and I'd like you to comment on this, unless the community hospitals can look at the business model and modify that business model so that you can compete, I don't think this trend is going to change. Partners needs to expand. They're going to continue to expand. Lahey is going to continue to expand. And they're going to try to get more of a market share. That's what organizations do. The question becomes, what will the community hospitals do to change that trend so that you can focus on areas of specialization? I'd like you to comment on that.
Well, first of all, I would say we haven't been able to expand in the state. Our network has shrunk by about 34% over the last 5 years or so. I think we've also done a very good job trying to control costs. Last year, our costs with the major payers was, I think the highest was 0.8%, the lowest -3%. So expansion is not our goal. Advancing our mission is our goal, and we need to generate the margins to invest in the future of the organization. We can't do that via price, and we can't, at least in this state, do it by growth. And so we're having to spend an awful lot of time on the expense side of the equation, trying to manage the margins by controlling expenses. And we wish we could pursue some of the other strategies more aggressively.
So I'd like to comment because I believe we're one of the community providers that is doing the types of things that you suggest. Our board, and through our strategic plan, we have very specifically invested in the organization, both on the facilities side, technology side, as well as physicians and the level of capability. So that's why we're able to keep more patients that we used to have to send downtown, because we can provide that level of care, very timely and very good access to care for that entire region. But to your point, it has to be a sustainable model. In order for us to be able to compete, we have to be able to have adequate reimbursement to do that. But we are showing that it does work. Patients will want to stay in the local community as long as, to your point, the quality and the access is excellent.
Just following up on that, I think that I guess I would question the growth for growth's sake assertion that you made. You know, under a full accountable care model, frankly, market share doesn't mean as much. Having the right services for the population that you are serving is really the way to drive your TME down. So you're not in an arms race for, you have a WisBit 3000, I need a WisBit 5000. It's what do you have to provide the right care for the community? And I think for us, the challenge is to invest in those kinds of service. And much like Howard talked about, you know, when we recruit physicians into the network, we recruit them and let them know that they will be they will be providing care both, whether it be at St. Elizabeth's and Kearney, or they'll be at Holy Family and Nashoba, to provide that care out in that community. in order to do that and do the investment that you need to have that kind of care provided in the community, you need a reimbursement level in order to do it.
So our community hospitals have grown over the last 5 years, and we've made a conscious effort to make additional services available there so that they could grow. With that said, our greatest growth has been in the home care arena over the course of the last 3 years. There's an awful lot more that we can successfully provide to our patients in the home care setting. It doesn't always work to the advantage of the organization from a financial perspective. We just recently commenced elective angioplasty at Beverly Hospital after approval by the state recently. Every time a patient receives care in that setting, the reimbursement to the Leahy Health System is 20 to 25% less than if that care had continued to be provided in Burlington. But we're doing it because it's the right thing to do for the community. It's better for the patients to stay close to home. It lowers our total medical expense for purposes of our population health risk contracts, accountable care. We've made a commitment, if we do the right thing, eventually it will inure to the benefit of the organization, and we've seen growth in spite of what the trends may be.
Yeah, go ahead.
And we know that one of the challenges in terms of keeping care in the community is many patients have the perception that, particularly those in the greater Boston area, that we have these renowned teaching hospitals in Boston, and they're not far to drive to, and we're going to go there to receive care no matter what. And they also don't really appreciate what you just said, Diane, which is a lot of our community hospitals can deliver really high-quality care, and that's just not that well known. So can we do a better job in terms of educating consumers about that and helping them to be part of the decision-making process about staying in the community? And I guess all of you can answer that.
Yes, I mean, I think you bring up an excellent point. That's something that, we block and tackle every single day, because it is such a challenge to change that overall opinion of, I can go to Mass General, I can go to BID, I can go anywhere, as long as patients have they have the choice and they have the right kind of insurance. But it can be done, but it takes a lot of effort, a lot of education, and really working with the primary care physicians to help them to explain, because patients will do most of the time what their physicians recommend. Yeah. And if they're recommending to go to our local, let's say, orthopedic surgeons that can do these procedures just as good as the Baptist, then they will believe it, and they'll end up staying in the community. But to change that overall opinion takes a long time, particularly because we are so close to Boston and we have so many renowned medical centers.
Tim?
Yeah, I was just going to build off that, and Diane, you referenced it a little bit. It's wondering the perception of people going to the community hospital, also the physicians in their preference for academic teaching hospitals, how much that plays into it, and what is the connection between perceptions amongst the patient population, but also perceptions and referral patterns amongst the docs. How do they work together, and it seems like that you have to solve both of those things together. I just wanted your opinion on that. Mm-hmm.
Yes, that's a very good point, because so our local physicians we basically share a lot of risk with them, and so we work with them the whole focus is keeping care in network in the community, and then all boats will rise because they benefit from that as well, both the primary care doctors and the specialists. But it really does take a lot of, and they want to keep patients in the community. I think there's no question about that. I think they're challenged a lot with a patient saying, I want to go to Mass General, I want to go to the Baptist, I want to go here. And so the physicians have to be comfortable in saying to the patients, you can get the same outstanding care at Lawrence General with this doctor.
I think the other thing, Rick, you mentioned the education piece, and I think Diane talked about that. I think the other piece that's important is because of the way the insurance is currently set up and with the caps on differences between the HMO and PPO products, there's not enough of a differential to really drive patient behavior. I think Diane said it, if I can go anywhere that I want, not knowing anything else, well, why don't I go here? I mean, I know when I was a CEO in a former system, we struggled with this around orthopedics, and orthopedics, I think, is a great example because, candidly, the vast majority of good orthopedics can be done in many of our community hospitals across the state. you know, we were part of the UMass system, and the private orthopods I had were as highly fellowship trained, if not more, than many of the orthopods at the mothership at UMass. But it took a long time to change that perception of care. My wife has a couple surgeries there. I get to tell people about it. It helped a lot, but it just took a while to get to the point where people understood that really good care can happen in our communities and is happening every day.
Anything we can do,
Rick,
John, to
yeah,
change that?
yeah, Rick, you asked, can we do a better job? Yes, the providers can do a better job.
Yeah.
Employers can do a better job. The state can do a better job. There's been a huge investment by the Commonwealth over the last 6, 7 years in taking a look at objective data relative to cost and quality. 20 reports, 22 reports, I don't know what it is, with the conclusion that there's not a measurable differential in the quality of care that gets delivered. But it can happen at the time that a patient is making a decision where he or she receives their care. I think it's got to be value-based decisions driven at the premium level for how the plans construct the benefits and how employers select benefits for their employees. I'm a firm believer that people should always have choice, but if they're going to make a choice that's not value-based and it's higher cost, those individuals should bear the responsibility for the costs associated with it, and that's not the way the market is typically structured right now. Yeah, we can do a much better job of educating.
Howard, if I could just ask a follow-up question.
Can I just respond to that
Sure,
question?
Peter.
Every conversation that we have with community hospitals in Massachusetts, New Hampshire, Maine, about these issues is the same. The question is, how can we enhance the secondary care that's available at that community hospital so that less care comes into to Boston? We operate telemedicine programs with dozens of community hospitals. We have our acute care general surgeons operating at multiple hospitals. We have our cancer center based at, I think, close to a dozen community sites. We're trying to actively enhance the care that's available in the community so that fewer people with secondary care needs come into Boston. I guess the other point I wanted to make is that there's a good reason why teaching hospital costs are higher than those in the community. I mean, we operate 4 missions at Mass General simultaneously. It's only the clinical mission that generates a margin and has to be used to cross-subsidize research, education, and teaching. Those things are at risk if our clinical margins are squeezed too much, and I don't think anybody in this state wants to see the research prominence, the educational prominence of healthcare in this region deteriorated.
I just had a quick follow-up question to Howard. As I remember, when we looked at your application for affiliating with Winchester, one of the very specific things you talked about was moving OB out of Leahy back to Winchester. Going to Diane's point about patient preference, did you do anything in particular in terms of educating your patients who might have had a preference to come to Leahy for a normal obstetrical delivery to move them back to Winchester?
So, Madam Vice Chair, I can't take credit for this. This discussion happened about 35 years ago, I think. When Leahy was built in Burlington, a decision was made at that point not to have OB services. And coincidentally, it was at the insistence of the Winchester leadership at the time that Leahy not have those services. So we don't have them today, but there are a number of other services that we have exported to the Winchester and Beverly community at the request of the staff there, services that were not being provided in that setting, which could be safely delivered. I'll give you a great example. Neither Winchester nor Beverly had thoracic surgeons available to them. They had been unsuccessful for a number of years at recruiting thoracic surgeons to practice in the community. We made a commitment at Leahy. We recruited 2 superb thoracic surgeons who cover both of those hospitals, and most of the patients that are referred to them today get their surgery at Beverly and Winchester.
Well, I gave you credit for having OB. Now, don't you wish you'd had the revenue from OB?
I want to go back to a technical point on metrics. Peter, you said that the metric we're using is hopelessly confounded, I think were your words, and John, I think you also were critical. So this is rather important. Here's the problem. We have strategic goals now, which have been defined by the analyses that the staff have done. Apparently, the Senate President has given us a peek that among those goals will be trying to move appropriate admissions to community hospitals. So we need a metric. And the metric we've been using is this percentage of admissions that we think could be safely dealt with in the community that are dealt with in the community. So if we take 100 cases that by this metric can be dealt with in the community, and we see how many can be and how many are. Peter, your critique was that the movement from inpatient to outpatient care would confound that, but I don't understand why it would confound it, because we're only looking at, maybe there are fewer such admissions, but we're still saying those 100 could be cared for in the community. So I don't quite get the logic. Maybe we're wrong, but it would be a mistake for us to proceed with a core metric of success that can be deceptive that way. So maybe some of you could comment on that and what might be a better way to judge whether community-appropriate admissions are actually going to community hospitals.
You know, one thing
John, I mean, just to clarify my point, I mean, if I'm making these numbers up, but if we're comparing ourselves to another community hospital, and during a year, that community hospital is now caring for 100 inpatients on the outpatient side, and Mass General is caring for 50 inpatients on the outpatient side. That will move those statistics in the direction that we saw. So I'm just saying that community hospitals probably have more care that can be shifted on a percentage basis to the outpatient side than teaching hospitals, and therefore that will cause these analyses to move in the direction you generally saw.
You might want to take it offline, because if I understand the metric we're using, we're only looking at the cases that either, whether they're at Mass General or at a community hospital, we're only looking at the cases that could have been cared for in the community hospital. The case mix doesn't affect that. It just is, it affects the denominator, but it wouldn't affect the ones we're looking at. So maybe this is too technical to be getting into here, but if we're going to proceed with that as a goal, then we would have to agree on the nature of the metric instead of arguing about the metric. That's all I'm saying.
Diane, you wanted to answer?
Yes, I just want, another perspective is, I think what we're seeing is not just the sort of lower level, community level of care, but more advanced care. So we're keeping more advanced care, whether it's surgery or cardiac or whatever, and we're seeing a significant increase in intensive care, very complex patients staying with us, and our CMI is rising significantly. Yeah. So that's the good news part of that.
That would be a different metric, and a very important one, Diane. You've educated us, all of you have.
We should add that metric.
Maybe add it. That would be the care of more complex conditions adequately in the community setting. But I spent time with staff on this other index, which is this admission perfectly fine for a community hospital without any adjustment in its capacity? And it's a very conservative list. I mean, it's stuff that you say, why would you ever send that to a tertiary hospital? So anyway, I think we should try to nail this down, because we don't. The last thing I think we should end up with is in discord with the delivery system as to whether that metric actually ought to be a goal.
Dr. Berwick, it gets back to my earlier comment about actively managing the process. Our chief medical officer, the system, worked with the emergency department groups at each of our facilities to define those categories of patients and the conditions of those patients that would be appropriately cared for in the community setting. It leaves the chance out, because that criteria is being screened with each patient that presents. In Burlington, for example, if they can be cared for in the community setting based on those criteria, they're afforded an opportunity to go back closer to home if that's their choice. So it's creating a process that's followed on a routine basis that has enabled us to move more and more patients to the community setting.
It would be interesting, Dr. Grant, to see if the list you've come up with is the same or different from the one that the staff are using here.
David?
I'd like to ask two questions, if I might. First is, John, you got a chance to comment on the Merrimack Valley and Holy Family share, but you didn't get a chance to comment on the Nashoba Valley share and the Morton share, both of which have declined. So I'd like to give you a chance to comment on those.
Thank you. On the, and I appreciate David sending this, the data ahead of time, so we'd have a chance to look at it a little bit. In the Morton market, our Morton market is ringed by two of our other facilities. So along Route 24, I have Good Samaritan, which is about 15 minutes to the north, which is really actually our biggest and busiest clinical site. It's Region 5's only level trauma center. And then at the south of 24, not that far down the road from Taunton, is our St. Anne's facility, which we've invested in greatly. In fact, we have another patient pavilion floor going on and will be open by the end of the year. So I think for us, I'd love to take a look at our data and then in the context of those three, because we actually operate those as a region just because of the geography there. With respect to Nashoba, you know, in looking at the decline, we are still struggling a little bit to see what the difference is, because we, as Howard has indicated, have brought a number of specialists back to Nashoba Valley that heretofore had not been there, and it was a bit surprising us to see that the percent of CADs actually dropped from there, particularly for those of you that know the air market. There's not a lot else around there, and to get to any of the academics from there, whether it be UMass or certainly downtown to Boston, as they say in the down Maine, you can't get there from here. So we'd love to take a look at the backup data for it, because it's that was the one that was odd to us. We understood Morton, and certainly I think the results that we saw from Holy Family show the progression of investing in both the facility and the providers and what can happen over time.
Thank you. My second question is for the entire panel, which is, I think I've heard conflicting answers to the general question: is it in your financial interest for discharges that could occur at a community hospital within your system to occur at the community hospital? And the two answers I've heard, one is, well, no, we get paid more when it's at the academic center, so therefore we need that revenue. And the second answer I've heard is, well, actually on our risk contracts, it saves us on the contract and we're not going to get paid more, so therefore it's a good idea to cut the costs. And so I guess I just want to know, for your typical patient, do you think it's forget about what's right for the patient and all of that. I just want to be, I want to pretend to be,
Let the minutes reflect that from Dr. Cutler.
We have no idea what's good for the.
Do you make money if the patient's in the community hospital, or do you make money if the patient is in the academic center?
Dr. Cutler, so you heard both of those comments from me, and it's welcome to our world. And our reality right now.
I'm told schizophrenia is on.
Yeah, but right now I'm confident in saying that we don't contemplate the patient's position in a risk contract or a fee-for-service arrangement when those decisions are being made. We made a commitment as an organization that we were going to do everything we possibly could to deliver the care in the appropriate location for our patients, even though in some circumstances it continues to be financially deleterious to the organization. But we don't expect our clinicians to look at the insurance of the patient in question when they're making that decision. So I believe that we are consistent in terms of how we manage that, irrespective of the patient's insurance. We hope that over time we migrate more to population value-based reimbursement so that we are rewarded financially as an organization for delivering the appropriate care in the lower cost setting. Right now, it hurts us in some cases.
Yes.
David, I would agree with Howard. We think that patients who can be cared for at community hospitals, who are cared for at community hospitals, that's a good thing. You're right, if you look narrowly.
But you win or lose?
Well, we lose on the reimbursement for that particular patient. We may make some of it back if that patient is in a risk contract, but we're also making the leap of faith that if we free up capacity at the MGH or the Brigham that's currently being used by secondary care, that we can backfill with tertiary quaternary care from around the country, around the world, and that economically makes it work if that tertiary quaternary backfill is there.
Let me modify your, see if I'm, I'm sorry. So when this law was passed, we were asked as the commission to look at the financial implications of, say, a merger. So you have a community hospital which is being paid $1 and a academic medical center which is being paid $1.25. Or in your case, where you have even an intermediary community hospital that's being paid $1.15 compared to the $1. Now, where we get nervous and where we are asked to comment is if what turns out to be the case is just simply by the merger. It's not that you're losing money. The question is whether the dollar either becomes $1.15 or $1.25 simply by the merger. So often, and here's where we get into discussions, and I think we need to lay this one on the table. Where we get the application, we go, oh, no. Yeah, we may be raising the rates from $1 to $1.15, but we're going to redirect enough patients so the net impact is, in fact, that we're going to save money. And then 2, 3, 4, 5 years down the road, we look and find it's either flat or it's negative. So what we've wound up doing is raising spending for the state from $1 to $1.15 or $1.25, and either it's flat or actually it's declined. So it becomes, on a financial basis, a lose-lose for the state. So it isn't and in order to change that, we realize how difficult it is. You really have to go back to your clinicians and say, I'm sorry, we made a commitment to do this, and we're going to have to do it because that's the commitment we made. So it's not a question so much, David, of losing money. It's a question of maybe we're being cynical, but I hope we're not, where we see these mergers, and while the promise is always to improve, the net impact is to immediately spend more money. So that's, Peter, that's where we've run into trouble.
I'm not sure which mergers in our case you're referring to. We haven't yet contracted for Cooley Dickinson Hospital.
No, we weren't talking about this one.
But I agree with you.
And no, it's not necessarily aimed at you. The truth is that we've seen this happen, and where the net impact, whether it's at your institution or at others, the net impact is to either immediately get an increase in the rates because of your negotiating capacity, not you, any of you, or second, to be able to negotiate harder in the future.
Peter, you and I can both be paranoid. I thought it was aimed at me.
It was no.
No, I mean, you're putting your finger on, I think, one of the great debates
listen,
in healthcare policy. What is the relative value of integration versus sort of fragmentation and, I guess, the heightened competition that comes with that? I'm a strong believer that, particularly as we try to manage populations of care, you need integration to extend electronic medical records across health systems.
I do too.
To drive down purchasing, supply costs that you can only do if you're merged. There are a variety of things, and to align incentives so that, I mean, Winchester Hospital has been near Leahy for a number of years. It wasn't until they merged that their incentives were aligned to make this happen. So I think integration has great potential, and we all need to work hard on trying to realize the benefits of it.
Does integration require ownership?
I think there are certain things that you can only do with ownership, like share supply cost savings, share benefits of better investments, of investment policies. So there are, and to align these incentives, expanded electronic health records. So I think there's some things that only ownership can provide. There are some things you can do with looser affiliations, but I think ownership certainly provides all the benefits that can come with integration.
Can I just pose Stewart's question like really starkly? Should our presumption be when we get a merger that says you should approve this because regardless of whatever else happens, we will send care back to the community, so you'll save money there. And then maybe rates will go up, maybe they won't, but that'll be a big savings for you. Should our presumption on the basis of this evidence be don't believe that statement? Because most times it's actually not correct, not factually correct when you go back and look at it, with the occasional exception.
So,
I just want to comment on this, but just because I want to actually compliment you. You know, from our perspective, and we are part of BidCo, and we have an affiliation with the BID system. But not all systems are the same, and I think that in any of these mergers are coming together, it really is the, as Dr. Grant talked about, the day-by-day managing these populations, and that takes a lot of work and a lot of effort. It doesn't just automatically happen, which I think has, you know, and it takes a while for these systems to start to be effective, but I think it takes real investment of the system to have the intention of pushing care to the community. And some do that better than others.
Dr. Cutler, when I look at the data for what the Commonwealth has accomplished over the last 5 years in terms of bending the curve on the cost escalation relative to the rest of the country, it's really quite extraordinary. I think part of what you're seeing with integration between larger systems is a commitment to making prudent decisions that ultimately result in costs being kept at a much lower level. And I think most of the systems in Massachusetts have demonstrated a commitment to it, an ability to achieve that, irrespective of the specific data that you're alluding to. We've made a commitment to keep more care local, and we've got results to show for it, and I think other organizations are capable of doing the same. Last thing I would mention, this is the most transparent state in the country. Nobody's going to succeed at doing something that's detrimental from a financial or clinical perspective to the state without everybody in the Commonwealth being aware of it. There are no secrets in Massachusetts. So I think that you've seen a commitment by each organization to do everything that we possibly can to reduce the escalation in the cost of care without compromising the quality. And I think we should be enormously proud of what's been accomplished.
So I'll answer your question directly, David. Having sat on that side of the table as a commissioner, I think the data, you know, is what it is. So I would take any of the mergers coming forward, you know, and have to look at the other value that is going to be created, because using that just as, I mean, we can all put that on, you know, or have our consultants put that together, but if the data is not actually borne out, then it's not actually true. So if there's other value associated with the merger in terms of total medical expense, or looking at the, you know, those cases that were done and what are the relative costs of those done in a community hospital setting versus an academic setting, and if you're willing to pay and continue to fund that differential, then, you know, certainly you could use that as a rationale to do it. Otherwise, your own data shows that it's not the case.
But John, you see what, one we see immediately. In other words, you do the merger and the next day, the dollar goes to $1.15 or $1.25. The hope is, and I want to be supportive of what you said, Peter, that is that the improvement in efficiency, the saving of money over time, but we see an immediate increase in spending with a hypothetical potential. And then when 4 years, and I'm on your side, Howard, in terms of how successful we've been. But with that said, there, you know, what David said has some bearing. We get uncomfortably skeptical when we look 4 years down the pike and said, okay, this did, and we didn't see it. And yes, it's hard and it takes longer. But I'm not trying to put you in our place, but you can see why we get a little uncomfortable with these promises. You could say to them, well, why don't you wait and don't raise the rates to $1.15 until you have the savings, which is what we're now trying to do with drug companies. You know, when you show us that you really are a successful drug, then you can get the big bucks.
So I continue to be troubled by the data that you show. I'd be happy to work with you to come up with something that I think was less confounded. But this is my first interaction with this commission, and I'm a little bit surprised that you're declaring defeat or failure when, in fact, I mean, the state as a whole came in well below its benchmark last year. Our healthcare costs over the last decade have grown the fourth lowest of any state in the country. So I guess I'm not sure why you're not declaring victory rather than failure.
Well, we're not declaring failure, but we're not declaring victory.
No, I know, and
So I would say I'm declaring us a work in progress. But let me, this is one data point. So this is one set of data, and I would hope this commission doesn't come to some conclusions based on one set of data. It is data, however, is important to put out in the public, and I'd say to you, Howard, I would say our transparency in the next few months is going to actually get much better when we start putting out some data that CHIA has that will be payer agnostic, but it will show some variation in some prices out there. But I do think that when, and to me, bigger is not better or worse, but when we do look at mergers and acquisition and organizations come forward and make statements of what we can expect from a Commonwealth, then it's important, I think, for us to have those dialogue about honestly, what is it we can expect from ownership, mergers, acquisitions. If people were here to tell me that we'd have extraordinarily better outcomes for the people that we are privileged to work with and care for, right, that would cut readmissions by X, and I'm not saying what the X is, or right, that we would, the things that do make us an outlier to other states in the United States, such as readmissions, unavoidable emergency departments for what should be in routine doctor's offices and oral health. No, I'm sorry, did I just like? Post-acute care. That we do still have higher discharges from acute care to long-term care and rehab facilities. If those were the outcomes that somehow people, hospitals and mergers were able to say that this would result in better patient outcomes, we might say, if we manage people's care well, we will manage costs. But this is some of the things we're seeing at this point in the iteration of this Health Policy Commission. So I think it is important to put it out to the public. I do caution us, like I don't come to one set of conclusions based on this, that we need to look at what the other drivers were, which is what you said. It was a complicated time. But on the other hand, healthcare is always a complicated time, at least in my lifetime. And the commitments that are made to us when people come forth with mergers and acquisitions. And I think that's in part of this dialogue today. And I just appreciate the honesty and the discussion of this, that it is complicated. And last time we looked, healthcare is complicated. And you all have different lenses in this and different roles. So I appreciate the, and even questioning some of our own data, so.
Don?
Yeah, I think we need three things to move forward. An agreement on goals, an agreement on the measure, on the way we'd know if we were getting the goal, and then the hard work of making the changes. And this conversation is a little confounded on this. I think everybody would like to do this cooperatively. Is there or is there not a goal to make sure that patients who can be cared for adequately in community hospitals are? It's not the whole ball of wax, and you're right, we have made some progress in the Commonwealth, but the current plan says to make further progress, we need to do that. We need to help people stay in the lowest, in the most local possible setting, not unnecessarily going to advanced care. It's really important whether we agree or not. Otherwise, we're not in it together. We have to work with tension. That's David's question about the business case. For the Commonwealth, the business case is clear. Yes, it's better for people to be staying in their local community hospital if it's adequate. The second is the metric, and you guys have questioned the metric, and that's not good. I mean, it's good for you to question it, but what's more important is that we agree that now we have a measure that we probably can use together to make progress. And I think this hearing shows we're not quite there. If you believe what you believe, because we've been using that metric and we plan to use it, this % of community-appropriate discharges that are in the community. Then the third is what to do, and this goes back to what Steward and David were saying. No, we have not made progress, not on that one. We're sort of stuck. The Commonwealth does not show a general trend toward more and more community-appropriate discharges staying in the community. That means we're not doing the right thing. That's not working. And so to me, the cooperative dialogue would be, well, what could? What are the changes that would be helpful in policy and payment and infrastructure, whatever, that would help you get that done? I just want to say, I hope we could reach agreement on those. I think to say, oh, no, it's okay, isn't an agreement because we disagree, or that metric doesn't work isn't okay because we don't then have a common metric, or that the goal's inappropriate. None of those contain the seeds of real progress here. I'm not sure enough that we're right to kind of table thump and say, let's definitely do it. But I think the inquiry and the dialogue are absolutely key. But I just want to say, I think it's not correct to look at the data as we have it now with this metric on that goal and say we're making progress on that goal. We're not, which means we have to make some changes.
So, yeah, again, did you want to say something? Howard, did you want to say something? Wendy is
Dr. Baruch,
thinking
apropos
about-
your comment, you can't look at one data point in isolation. I mean, we're getting to the point now, I know our experience at Leahy, we're at about 40% of our patients are in value-based contracts of some type or another. I lived in another organization before coming to Massachusetts where we got to the tipping point at 50%, and we said, we're all in. We're going to deliver care in a different fashion. We're going to make investments differently, and became completely focused on total medical expense and driving patients to the appropriate setting for their care. We're getting close in Massachusetts to be able to behave differently in that regard. But any one of these organizations' ability to make investments in the type of resources that you want us to invest in, and our example at Leahy is our behavioral health programs, which we inherited from our partnership with Northeast, which is a remarkable array of 40 different locations. We deliver the largest percentage of care to the mass health population in that program. Our ability to sustain those services across the Leahy health system and in a number of communities where Leahy does not otherwise provide any care, but we've kept those services anyway, is predicated on behavioral health at Leahy being part of a much larger system. And our ability to expand those services is going to be dependent on the scale that's required to be successful in population health. So one size does not fit all, and one data point does not answer the question. But I commend my colleagues, both at this table and across the Commonwealth. Amazing work has been done here, and when I compare it to other states around the country, we are light years ahead with still a long way to go.
And I would just second what Howard said. I don't think there's any disagreement on the goal. We desperately want to move more care to the community, and we are spending an enormous amount of energy trying to do that with lots of hospitals in the region. It is hard work, and I'm not sure. Again, I'm not sure that work is reflected in the data quite yet. But there's no disagreement over the goal.
Well, that's great. I said, again, we were just, you may not have been here this morning, but we had a presentation early on. So forget about individual hospitals, and this is not aimed at any of you, but when you looked at these numbers, the share of community-appropriate discharges at the community hospitals had declined from 2011, which was 59.8, to 57.5 in 2016. So not only are we, this is maybe statistically not significant, but it's not trivial when you take it as a percentage. So if we're in agreement, and I like the way Don laid it out, in the goal, and we agree that it's not easy, but it doesn't mean that we shouldn't keep pushing. And as the Secretary said, and I said, we're not prepared to declare victory. We are pleased with the results. I'm not sure how much of it is this. I think it's been overall you're concerned about costs, all of your institutions, and we commend you for that. But we are going to keep pushing until, we're convinced either that we've done as much as we could or that it's not a good goal, which is another area. So that's really what it's all about. One other thing I want to say, we had a wonderful panel this morning about the difficulty that all of your institutions have with certain kind of patients when it comes to readmissions and stuff like that. And we came to, I think, a conclusion that everybody shared, that one of the key, if not the key, for reducing readmissions and improving quality is to invest substantially more money in what are now called, non-traditional clinical care type services, community type services. And since we're not going to be able to add more money, the only way we're going to be able to do it is redirect money from the clinical care side. So that's what it's all about. So we're not at different sides, but we are going to keep pushing. Anybody? David?
Mr. Chairman, I just wanted to add and reiterate, this was one data point, and I think on the last slide I showed there was at least 10 other ones that we are currently examining, so welcome the opportunity to work with this panel on that. I think I just would ask one question really just to be specific on what some policy options and recommendations this panel might have for us. Each of you mentioned payment incentives or lack of insufficient incentives on the consumer side or on the member side. And one of the recommendations that the governor had made is around increasing some of the differentials that exist between tiered and limited network products. The Attorney General's office has recommended perhaps tiering based on your PCP. Interested in the panel's perspective about how a product design or innovative care design could help create greater incentives for patients to seek out high-value care.
David, if I could just make two comments. We and just our own experiment, we're self-insured, so we created a tiering system for all of our employees and their families, and it actually shifted to a domestic utilization of our hospital and providers up to 70%. Wow. So it was very, very effective in our local situation. But if you're asking also about policy issues, I do have to leave one more time with the issue of price variation, because we are an independent organization, one of the few, and we are part of the solution set. We get it. We think we're doing the right things. We're not going to be sustainable unless that can be fixed. So I really hope, I've heard more discussion about that today, and I hope we can really see something happen.
I heard Dr. Wagner's comments this morning on the impact of unwarranted price variation on innovation and the ability to make appropriate investments. At Winchester Hospital, we were participants in the most recent round of CHART grants. We saw a 40% reduction in readmissions for select populations based on the mighty infrastructure that we created to tend to the needs of the most complicated patients. Our ability to make that level of investment right now, given the price variation situation, makes it a real challenge. And it's what most organizations in the Commonwealth are facing. The good news is there's nothing mystical about what needs to be done any longer. There are enough organizations across the country who have demonstrated their ability to reduce total medical expense without compromising, in fact, enhancing quality. But if you look at those organizations by and large, they're larger integrated systems, many of whom have their own insurance product, who are making investments with the premium dollar in those areas where they know they're going to have the greatest impact. And that's not possible for most organizations right now.
I too worry about price variation, but maybe in a different way than my colleagues. As we've done more business in New Hampshire and Maine, we hear from the insurers there that they're happy when patients come into Massachusetts because the prices are lower in Massachusetts than in the surrounding New England states. And secondly, when I visit colleagues at other prominent academic medical centers around the country, like at UCSF, where they get paid significantly more than us and are, because of the wealth that's been created in that part of the country, are raising 3 times as much in philanthropy. I worry that too much focus on price variation in this community puts the life sciences cluster that is unprecedented here at some risk.
John, you get the last word.
Oh, fantastic. I think there's two things, and we talked a little bit about them. I think the policies around the narrow networks and trying to drive more behavior and make it a real difference for people is critical. And I think, and I missed the governor's conversation this morning, but if that's one of the things that they're already looking at in terms of loosening the ability or that rate cap in terms of the percentage difference, I think that'll help tremendously. And I know through our testimony, through our written testimony, and Steward has talked about this for some time around asking to index the cost on a weighted average payer ratio, so that in terms the rich don't get richer while everybody's moving. There's less, and we get less of an impact at places like Diane's and mine than necessarily at some of the higher payment locations.
Well, I want to thank the panel. I mean, this was a very thoughtful and discussion, and we look forward to working with you. And as David pointed out, if you have ideas on how we can use a little different metrics, that would be great. So thank you very much. Okay. Yeah, I know, yeah. What's that? Yeah, for the people. Okay. Well, that was good. Listen, we had to push them a little bit.
Question.
All right, we do have one final presentation for today before we turn to the public testimony, so please ask people to return to their seats.
I just don't want
Well, that's the other problem. I don't want them to speak to me, especially them.
Okay, it is really my great honor to introduce our next presenter, our final presenter of the day before moving to public testimony, Ms. Sandy Winsky from the Attorney General's Office, Assistant Attorney General. Thank you so much for being here today. The Attorney General's Office and the Center for Health Information Analysis are named in our statute as co-hosts for today's event, and the Attorney General's Office has been a leader over the last decade in terms of providing analysis and information to our healthcare policy discussions. And so I'm pleased to have you here today to speak to some of the Attorney General's work. And I think many of the themes that were discussed throughout this day are really a perfect tee-up for some of the topics you want to discuss. Where do we find the resources to be able to make appropriate investments in community health and in public health? And is our healthcare system matching the resources to those most vulnerable populations? So look forward to your updates on both of those topics. Thank you.
Thank you. Thank you, David, commissioners. So I'm here to share an update on the AGO's work to modernize our office's hospital and HMO community benefits program to better align this program with broader population health initiatives in the Commonwealth. I'll spend a few minutes describing the current state of community benefits in Massachusetts, but we'll quickly turn to how we think a couple of strategic updates can improve the impact of these critical dollars. Our office is so grateful to Commissioner Berwick, who serves on our advisory task force on this issue. He and his staff at IHI have been very generous with their time on this project. Finally, I'll turn to some data on the related question of how hospitals shoulder the responsibility of providing care to the most vulnerable populations in the Commonwealth. As David said, a topic that fits in so nicely with the discussion that's already begun today. Hospitals have long been recognized for their charity care and efforts to improve community health. Community benefits are investments by hospitals and HMOs that further their charitable mission of addressing health and social needs in their communities. These investments are guided by triennial community health needs assessments. The term community benefits includes the costs associated with providing free and discounted care, as well as contributions to support the health safety net and direct programs run by hospitals and their partners and funded with these dollars. So in Massachusetts, roughly half of community benefits spending is charity care, and half are these direct programmatic investments. Community benefits reporting programs have developed in many states as well as federally through the IRS. And here in Massachusetts, the Attorney General's office promulgates voluntary guidelines that describe how to plan, implement, and report on community benefits programs. This slide surfaces some of the pressing reasons for an update to this program now. So first, there have been significant changes in sister programs, like the community benefits reporting required through the Affordable Care Act. This means that we have an opportunity to decrease administrative burdens on hospitals so that these resources can be moved from reporting into the community. The Department of Public Health has also recently updated its statewide health priorities as part of the new determination of need regulations. Speaking with one voice with DPH on issues of statewide public health priorities will have the added benefit of bringing our community benefits guidelines up to date with advances in the evidence base about the really critical role of social determinants and health disparities in shaping population health outcomes. Second, we have an opportunity to improve coordination across hospitals and with the communities that they serve. As we heard this morning, moving the needle on population health can't be done effectively in silos, and there's more that we can do to support collaborative approaches to community benefits, including ensuring that as our hospitals and HMOs pilot innovative community health programs and identify best practices, that those lessons can be shared effectively across the Commonwealth. Finally, the next two slides dig into some enhanced programmatic reporting that we think will facilitate a dynamic and coordinated approach to these investments. So this chart shows the scale of annual hospital community benefit spending in Massachusetts. Annually, over the last 10 years, we've seen hospitals report in total between $550 and $650 million each year in community benefits. That doesn't count an additional $150 to $200 million each year reported by our HMOs. Here we're looking at 2016 hospital community benefit spending. And I want to draw your attention to the large blue wedge labeled community benefits programs. So you can see that over $300 million was reported to our office last year by hospitals as community benefit program spending. Now, as we approach these updates to our guidelines, we think it's important to be able to break down this wedge, these programmatic investments, and to do so thoughtfully in ways that can help guide our systems towards highest impact programs. So this is just an example, a mock-up of two different ways that would be helpful to better understand that $330 million in annual spending. One way, illustrated on the top right, is to have a view of the type of investment. So for example, a breakout of how much a hospital spends on community health education as compared to access or coverage supports. Similarly, in the bottom right, another approach to this kind of transparency would be to get reliable mapping of these investments by health need. So for this mock-up, we've illustrated DPH's 4 focus issues, plus an additional bucket for local needs identified by the hospital's community. So an approach like this would allow state agencies, potential community benefits partners, the community themselves, to look at these reports that are publicly available on our office's website and see clearly how much of an institution's community benefits program spending was focused, for example, on substance use disorder or on mental health. We look forward to watching many related initiatives develop as the Commonwealth pursues new approaches to curbing healthcare costs through population health management, the Mass Health ACO program, the healthcare innovation and investments here at the HPC. The AGO is eager to be a good partner in working towards our shared goals of maximizing the impact of these initiatives. As a closing thought on investment across communities in Massachusetts, we wanted to keep to a theme that is run throughout the AGO's work, which is keeping vulnerable populations front and center in our policy discussions about the healthcare market. The HBC has long examined the proportional mix of Medicaid compared to Medicare, compared to commercial populations served by competitor hospitals, and has shown that different populations are served by different providers. It's also well understood that commercial and public payers reimburse at different rates, so this mix has an impact on a hospital's financial health. We looked at the same question of payer mix for the state's largest market, Eastern Massachusetts. And there we found that the largest hospital systems are significantly tilted towards a higher share of commercial patients. The largest 2 systems have 50% of the region's commercial revenue represented in the top red bar, but only 37% of the region's Medicaid, health safety net, and connector care revenue represented in the bottom red bar. But payer mix isn't the whole story. We know that different populations have different vulnerabilities, even in the commercial market. Last year, at these hearings, we documented the link between health and affluence and shared this chart with you. As you'll recall, this chart plots average health risk score, a measurement of health need, against average community income. So on the left, we have the lowest income communities in the Commonwealth, and you can see that they have the highest risk scores, meaning that on average, they're the most sick, the most burdened with health needs. This chart shows that the 3 largest commercial payers, for each of these payers, lower income communities have higher health risk scores than higher income communities. And this is not surprising. And this reality is borne out in the latest data on the opioid crisis. The Health Policy Commission reported in their recent report that the lowest income Massachusetts communities have experienced the highest increase in growth of opioid-related discharges, up 75% from 2011 to 2015. This slide is also an incomplete picture of the stresses associated with being low income. This medical risk score represented here doesn't include the social risk element that was presented really powerfully this morning. So in prior years, we've presented data on disparities in payers' healthcare spending by patient income. And we found year over year that commercial payers spent more on the care of high-income patients as compared to low-income patients, even after we adjust for health risk. So this year, we wanted to look at differences in where higher and lower income communities got their care. So even in the commercial market, we wondered how significant those differentials would be. We found that the differences in average patient income score were substantial across hospitals and systems. We used discharge data to create an average patient income score for each hospital and system's commercial business. So a score of 1 represents a patient from a zip code with an average income in the lowest quintile statewide. A score of 5 represents a patient with a zip code from a zip code with an average income in the highest quintile statewide. And we've calculated an average here based on discharges. So these findings are not surprising, right? We know hospitals are located in different places and they serve different communities. What we've done here is to quantify this distribution to produce a snapshot of the average income of the commercial patients served by different systems and hospitals. What this chart says is that your zip code in Massachusetts is tied not just to your health, but also to your health care. This is important to our discussion at these hearings for several reasons, many of which have already come up in the testimony and presentations from earlier today. The first is this totally critical question of how we match resources to need, right? We can't talk about population health statewide. We need to bring socioeconomic status and community health burden to every conversation about distribution of resources, whether that's analyzing population-based risk budgets or apportioning cost growth reduction targets. There's also a lesson here for our community health investment programs, right? The entire notion of community benefits is investment in the infrastructure and the people, the places who promote determinants of good health. The systems that are spread the most thin, caring for the most vulnerable patients, both commercial and mass health, these are in areas where community health investments have the most potential for impact. So we know that certain institutions have more resources available for studying and piloting community health initiatives, and we need to spread that learning so that it's available for communities who need it most. So these conversations about the link between health and place are happening across state government and will only become more important as we move towards more population-based financing of care. So these are just a few obvious examples and opportunities for coordination on these questions here in this slide. It's, of course, not an exhaustive list. At the Department of Public Health, the new regulations include an explicit requirement that determination of need applicants demonstrate assurances of health equity in their proposed projects. At the Health Policy Commission, the cost and market impact reviews include the role of the provider in serving at-risk, underserved, and government payer patient populations. Performance improvement plans also present an opportunity for targeted goal setting that's conscious of the challenges facing providers who care for the most vulnerable patients. And the AGO, of course, has oversight as well, including our monitoring of the state healthcare market and our management of the community benefits program. Happy to take comments or questions if we have more time.
This is really very interesting information. Thank you so much. I was fascinated by a number of it. Questions or from anybody? So I have one or two. So I've also often looked at the broad definition of the IRS, and it does seem to me to really not capture really what you're aiming at, which is just throwing in all Medicare and Medicaid, particularly Medicare, as a community benefit. And I like the way you're digging in much deeper to say, okay, we'll buy this community benefit, but we really want to look at really what is this community benefit and whether this would lead to any fundamental changes in the way we define community benefits, and basically either throw out certain activities which are now considered or add others which are now not considered. I don't know whether you have a new list coming up at some point.
Yeah, well, I mean, so this is all work in progress for our office. You know, we've been meeting with our advisory task force at public meetings. We've got a series of public listening sessions coming up. So we've certainly not reached the end of our wrestling with these questions. But, you know, one of the exercises we're going through now is taking the full list of investments and activities that are credited by the IRS as community benefits and looking closely at what has historically in Massachusetts fallen under that rubric. And, you know, I think our goal of aligning with the reporting as required by the IRS doesn't mean deferring whole hog to their definition of what Massachusetts communities need. So we're being very selective when we look at the different categories that are counted in Massachusetts.
What about things like the kind of services they provide? So where they provide inpatient mental health, they might get a higher grade than if they're providing certain kind of high margin, even if they're being paid by, you know, different payers. I mean, some services we know are higher margin than others, and some are lower. And as a, as one measure of community benefits or lack of.
So the provision of subsidized health services is encompassed in the IRS reports. And in Massachusetts, historically, we've allowed hospitals to report to us costs incurred in providing low-margin services, but only if it's consistent with the needs that were surfaced in their most recent community health needs assessment and consistent with their plan for how they're going to address those needs. So not sure exactly how we'll end up coming down on that issue in the revised guidelines, but there's been some reporting of low-margin services in the past.
Right.
I'll just take the 10 seconds. So I get to serve on the task force. I'm very excited by what's going on now, the alignment that Sandy's talking about. We're looking at close to $400 million a year that is devoted in the Commonwealth to what's called community benefit. If that were aligned, if we decided as a Commonwealth that working on obesity and substance abuse and mental health integration were going to be themes, the opportunity here to have hospitals all over the Commonwealth working together, learning together, and achieving measurable success, I think is phenomenal. And I think there's private sector support that would be recruited here. So I feel very lucky to be involved in this. From the Commission's point of view, some of the stuff we're looking at around social determinants or substance abuse, we could align with this. And in fact, the CHART program could align with this a little bit. So there's a real chance for synergy here.
Well, I want to thank you very much, and we look forward to continued effort in this area and coming before us again. Thank you so much.
Thank you.
All right, now, we're now at the session with having comments from the community, from the public. We're particularly interested in hearing from the consumer perspective, from Healthcare for All, and from the business community, from the Retail Association of Manufacturers. And we're also going to hear from Cynthia. Good to see you again, Cynthia.
Hello, Professor.
All right, so first, Amy, you're going to give us the perspective of Healthcare for All and all the good work you've been doing.
Yes, thank you. Good afternoon, and thank you for the opportunity to testify here today. My name is Amy Rosenthal. I'm the new Executive Director of Healthcare for All. As you may know, Healthcare...
Excuse me for 1 second.
Oh,
I just
sure.
want to remind the group that we have a 5-minute, so...
Yes, thank you. As you know, Healthcare for All works towards a consumer-centered healthcare system that delivers accessible, high-quality, culturally competent, and affordable care for everyone, but particularly our most vulnerable populations. Though Massachusetts has the highest rate nationally of insurance coverage, Massachusetts consumers are still experiencing the high cost of healthcare in very real ways, from rationing medications to save money, to struggling to pay unforeseen medical bills, to choosing coverage that means lower premiums but potentially higher out-of-pocket costs and disruptions in their continuity of care. These problems are not spread evenly throughout our populations, and we know that people of color, immigrants, those with low incomes, and other groups suffer disproportionately. So as we work to improve healthcare in Massachusetts, we must keep in mind that addressing these disparities needs to be a top priority. So I want to just cover a couple of brief topics. We heard a lot today about the continued high cost of prescription drugs. These costs are felt directly by consumers, and through our helpline and at community events, we hear from consumers who are faced with making very difficult choices about life-saving medications versus paying for their basic living necessities. In 2015, Massachusetts spent $7.3 billion on prescription drugs, yet we have little to no insight into how drugs are priced and whether consumers are truly getting the value they deserve. That's why Healthcare for All is strongly supporting legislation aimed at solving much of the mystery that surrounds what consumers are getting for our money. And transparency would allow the public and policymakers to understand the causes of high prices and cost growth. And we look forward to learning more about what the Senate will propose in this area. We also support investment in evidence-based education for doctors and other prescribers. For several years, the state funded academic detailing, a program which provides unbiased, evidence-based information about the value and efficacy of drugs to counter the marketing of drug manufacturers. We support authorizing a permanent academic detailing program, and we think the Health Policy Commission could play a key role in administering such a program. Second, just as the mouth is part of the body, oral health is part of overall health, and people cannot be healthy unless they have access to dental services that they need. Poor dental care, particularly gum disease, increases the risk of serious health problems. And poor dental care also raises the cost to the medical system. A Health Policy Commission found that in 2014, there were 36,000 preventable oral health visits to emergency departments in Massachusetts, which cost the system between $14.8 million and $36 million. Approximately half of this was paid for by Mass Health. We support a number of cost-effective policy changes that would improve oral health care, including integrating oral health into medical care and authorizing dental therapists and telemedicine to expand accessible oral health. Another troubling trend highlighted in the recent CHIA report is increased cost sharing. As we heard today, high deductible health plans comprise 21.8% of the market, as Massachusetts employers and consumers continue to seek out health plans with higher deductibles in exchange for lower premiums. High copays and deductibles are an obstacle for people getting the treatment they need. And that's why we support a strategy called value-based insurance design, which aligns cost sharing with the value and cost effectiveness of the drug or service. This would build on a provision in the ACA which waives cost sharing for prevention screenings and extends this to some highly cost-effective care, such as asthma inhalers, insulin for diabetes, or generic hypertension drugs. Another issue that's drawn much attention is surprise out-of-network billing, which causes consumers to be faced with unaffordable medical bills, yet we still do not have comprehensive protections in place at the state level to prevent these scenarios. And finally, we believe that addressing social determinants of health is critical to effectively keeping people healthy and preventing the onset of expensive medical conditions. One proven way to do this is through the Prevention and Wellness Trust Fund, which works in partnership with ACOs, medical providers, community organizations, and local authorities to promote healthy behaviors and community clinical linkages. The funding for this program expired this summer, and we support providing a permanent authorization and funding for the program. We hope that the ACOs will take steps to address social determinants, such as appropriate screening and meaningful collaboration with social service providers, and we recommend that the HPC work in conjunction with Mass Health to collect and disseminate information about these interventions and assess the efficacy of these interventions over time. Thank you for your leadership in prioritizing the needs of consumers as it relates to improving health care costs and quality. Healthcare for All welcomes the opportunity to work with you in any opportunity, and we thank you for taking a holistic approach to thinking about this.
So Amy, I really want to take the opportunity to welcome you. I know this is the first cost hearings that you've come and join us, and Healthcare for All has been extremely valuable team player in our broader effort. So welcome to Massachusetts.
Thank you very
Healthcare
much.
for
I'm
All.
excited to be here and looking forward to working with all of you.
And we're always interested in the business community and the retailers. And if we don't, for some reason, my friend over here reminds me. So John, it's good to see you again.
Thank you, Mr. Chairman, Commissioners, David, and staff. I want to, first of all, just thank you for, so many of you have been at this for many years now, and you're doing great work and important work. But, you know, I just wanted to make a few points this afternoon. Number one, despite what some may say, now is not the time to take a victory lap. There are some advances that we've made. But, you know, if you're a small business or if you're an employee of a small business here in Massachusetts, you know, you're not seeing, 2 or 3% increases, in your healthcare costs. I came before you when you look to go down to 3.1, and thank you for doing that. That's an important step. But, our members saw an average of 12% increases back at April 1. Now, that didn't translate into 12% premium increases. Some of them went to a higher deductible plan, more cost sharing. Some of them dropped dental coverage. I think a huge percentage of small businesses today and their employees do not have dental coverage. Others, frankly, just held back on wage increases, held back on hiring. There's only so much money to put into payroll if you're a small business out there, particularly if your sales are not going up, if your sales are flat to down, yet your mandated costs, particularly your biggest, your healthcare, keeps on going up. It's supposed to be going in the opposite direction. You want your sales to go up, your costs to go down in order to stay in business and be profitable. But unfortunately, it's going in the other direction. We have more work to do. And one of the things that I really would like to see the Health Policy Commission look at is the merged marketplace. Merged marketplace is a really big problem here, I believe, in Massachusetts. We became the only state in the country to merge small group together with the individual marketplace. And, and that brought in several years of double-digit increases. And that was made far worse under the ACA, which did away with state rating factors. We had 13 rating factors here in Massachusetts. The combination of both of those actions really created a unique situation for small businesses and their employees in Massachusetts, which arguably puts them in such a severe, extreme discriminatory position, unmatched really across this country. I mean, some would argue that marketplace, the merged marketplace, is really a pilot program for single payer, and it's failing miserably. These employees of small businesses are seeing their increases go up year after year, and we've got to deal with it. We have to, frankly, if the Trump administration doesn't give us the kind of flexibility that the Baker administration has asked for on rating factors, we would call on Beacon Hill to immediately begin to work to unravel the merged marketplace and go back to an individual and small group marketplace next year. We also have to, there are other factors at place here, whether it be state mandates, assessments, but we've got to look at the fact that small businesses and their employees are suffering and they can't continue to see these increases. And finally, let me just say, you've got a lot on your plate going forward, and the issue of competition versus expense control is a very, very important topic. I, for one, believe that the nonprofit healthcare industry is very poor at expense control. And the same thing happens in higher education. It happens in a lot of groups where it's so easy just to ask for more money, whether it be from premium payers, tuition payers, or taxpayers, or employers. But the reality is they need some more restraint. And there's probably too many of them out there asking for more money, and sometimes they frankly look better in the annual U.S. News and World Report by asking for more money. So we do probably have too many people asking for more money and not controlling their costs like they should. But on the other hand, you have to balance that with the importance of competition. We all live here in New England. You go into a small town, you see one gas station with a big sign that says how much the gas per gallon is. It's all very transparent, but usually it's very high in that one gas station town. If you go into a town with two gas stations, it's still very high. Why? Because they match each other in price. And it's the very same gas. It's the very same gas coming from the same wholesalers, same quality, no matter if it says Mobile or anything else, Cumberland Farms. It's the same gas. But something wonderful happens when you have that third gas station. When you have that third gas station, that is when the consumer starts winning. Someone's always looking for an edge. They're looking for the volume, and they're going to look to cut their costs and attract more consumers into their front door. So you have a lot of work coming for you in the coming months. I just would ask that you look at ways that we can get these providers to cut their expenses and look at some consolidation, but not, I would urge, at the price of less competition or less choice for the consumer. Thank you.
Thank you very much, John. Cynthia, again, welcome.
And for another population health perspective. Again, my name is Dr. Cynthia Champel, and I wear many hats, but I'm here on behalf of Stop Tuberculosis Massachusetts, a group of TB experts and advocates for TB elimination, an affiliate of the Stop TB USA. We are very pleased to respond to the request for testimony today. Record year for measles in Minnesota. Record year for West Nile in California, that's deaths by West Nile. Zika spreading like wildfire. Chikungunya following right on its heels. Our daily headlines show infectious diseases in old, new, and drug-resistant flavors are increasing our suffering, avoidable ED visits and hospitalizations, disabilities, and healthcare expenditures. Moreover, every healthcare provider relies on our public health infrastructure for some type of support or other. From diagnoses to disease surveillance to outbreak management, the list is actually way too long to list here. Tuberculosis requires special attention because of its complexity. However, TB offers insights into the benefits of disease preventive efforts and the huge costs of neglecting the same. First, a quick refresher. TB is caused by a mycobacterium spread through breathing. The disease is preventable as well as curable, although there are serious side effects such as permanent loss of hearing and liver failure for drug-resistant TB treatment courses. TB is the leading infectious killer in the world, claiming more than 1.5 million lives a year. Now back to the matter of healthcare costs. Increasing generic drug prices highlighted by the HPC are of especially grave concern in the case of infectious diseases because the population, rather than an individual patient, is subsequently impacted. Last year, the price for cycloserine, a decades-old specialized antibiotic, was increased by 300%. Cycloserine is the fourth anti-TB tool affected by price increases or stockouts or other types of rationing in as many years. This particularly impacts Massachusetts as it suffers from an above-average rate of drug-resistant TB. More than 1 in 5 of our active TB cases are drug-resistant, and we have a rate of the extremely complicated multi-drug-resistant TB, or MDR, double the national average. We suffered another increase, or so far we're already above we've surpassed our 2016 number in 2017 so far. A course of regular TB will cost us around $40,000. MDR cases cost between $200,000 and $1.3 million each. Progress against TB, point 2. Progress against TB in Massachusetts has long been stalled due to budget and personnel cuts. The recent fiscal year 18 budget is the second year in a row for which the state public health lab line item received lower appropriations than in any of the 3 initial proposed budgets. These budget cuts and continuing fallout from the early retirement incentive program have resulted in diagnosis delays and a likely increase in the reservoir pool of TB infection, or LTBI, estimated at 300,000 persons in the Commonwealth. The only real progress, and this is happy news, against this primary source of active TB disease is the Lynn Community Health Center's innovative model for expanding TB preventive services within the primary care sector. Again, integration is something that's been coming up today frequently, and this is no exception. When the current CDC funding runs out, because they're a unique in the nation model, it will be imperative for the Commonwealth to continue and expand on their success in the areas most affected by TB infection. Finally, point 3, the trend of increased patient cost sharing identified by the HPC in the recently released state auditor's report regarding Chapter 224 and highlighted just now by Amy from Healthcare for All is of special concern where infectious diseases are involved. It has long been documented that any out-of-pocket charges reduce acceptance of and completion of TB and TB infection treatment. This is a recipe for very expensive outbreaks, such as the multi-million-dollar TB outbreak in Massachusetts in the 80s, the billion-dollar outbreak in New York in the 90s, and the multi-million-dollar TB outbreak in Wisconsin just 4 years ago. I might add about the Wisconsin outbreak that at least $2 million of the $6 million came out of Medicaid. To avoid further such incidents in Massachusetts, we recommend the HPC take concrete actions to strengthen infectious disease prevention, including 1, urge the administration and legislature to offer first-dollar coverage for highly cost-effective prevention services and medicines, especially those for TB. Work with the administration to urge the NIH to protect public interests, particularly in the case of medicines essential for population health. for example, using its powers under the 1980 Bayh-Dole Act. And third, urge the legislature and the administration to increase investment in infectious disease infrastructure and personnel, especially for this very costly drug-resistant TB, so we can avoid it before it happens.
Thank you very much. Are there any comments or questions from commissioners of the three? I want to thank the three of you for your thoughtful presentations, and we look forward to seeing you in the future. I think, David, I think we are adjourned for today. We will be, what? We're going to take a photo? All right. Hold on for 1 second. So tomorrow we will again convene at 9 o'clock. And we look forward to all of you coming tomorrow. Okay, with that, we are adjourned. Thank you.